Hello, can you hear or see me?
Hello, Professor Stephenson. Yes, we can both see you and hear you.
Sorry for joining late. I've not used WebEx before. We don't use it, so but I seem to be in now.
Yes, we are.
How do I share my slides in WebEx? How do I do that?
Below, at the very bottom of your screen, there should be a share button.
Share, yes. So the browser doesn't support sharing, so I've got to switch to the desktop app or use the latest version of Chrome or Firefox. So I'm going to come out and come in again using
Let
me try and come out using Google Chrome.
Yeah.
I'll be back with you shortly. Okay, you have the slides. Excellent.
Yes, I can share yours. You just tell me.
Okay.
Unless you have updated them from yesterday, we have your slides. Yes.
No, that's an immense relief.
Okay, good.
So do you want me, so I might have missed the beginning or the introduction. Do you want me to start or do you want me to wait until you have started the meeting?
No, please. Yeah, we need to start now. We were waiting for Delane to join, but
Okay.
we will start so that we don't have everyone waiting. Okay.
Okay, let's go to the next slide then.
So no, sorry, you're not first. It's our colleague, so it's not. Not
excellent.
Not yet.
Okay.
Sorry, just a minute.
No problem. I'll go on mute. Okay.
Okay, thank you. Yes. So good afternoon, everyone. Thank you for joining. This is the first time that ECDC is doing a joint webinar with ESPID, the European Society for Infectious Pediatric Infectious Diseases. We hope to get very interesting, to have a very interesting discussion today with clinicians and public health representatives. We have people joining from our COVID network, the European COVID network, but also the NITAGs. And we would like to start, I will give the floor to my head of section, Thomas Hoffman, to say a few introductory words. And I will continue with a short introduction, waiting for Delane, the president of the ESPID, to connect. Thank you. Thomas, can you please? Thank you.
Yeah, thank you very much, Agoritza, and thanks also the whole team behind on this work on children and COVID-19. I think it's very, very important, and we're very much looking forward also to this discussion. I mean, for us, it's very important to have these strong links to science, to scientific work, to really also understand better what are the risks, what is the situation, but also to see how can we better maybe define what is behind by having clearer definitions or descriptions. And I think in that sense, it's very useful or important to really have this sharing of experiences across countries to see what has been done so far, what work has been done, what criteria have been used, how does the situation look like. So I think this is really important, and yeah, I don't want to make long words. Thank you very much for all your work, for presenting today, for sharing your experiences, and warm welcome from ECDC side.
Thank you very much. Apologies, I forgot to introduce myself. I'm Agoritza Baka. I'm one of the ECDC experts on preparedness, but also a pediatrician. And I see Delane has connected. Can I have you please present yourself and ESPID and our work? Thank you. Yeah, we see that Delane has some network problems, maybe for connection. What I can do is I can share my screen, and I hope you can see my screen. And I would like just to say very few words on this collaboration with ESPID, which started this with a short exploratory questionnaire. Very simple, as you can see on the slide. We were just trying to find out what is going on in Europe regarding long COVID or post-COVID condition in children. And this electronic questionnaire was mailed to all ESPID members in July. We ran it until September. And I can show you just very shortly that about 40% of the respondents said that yes, we are collecting data systematically on post-COVID condition in our country. And here you can see that most of the activities are a mixed initiative between public health and academia or hospitals or something like that. In blue, it's also the non-EU EA members of ESPID who responded. We know that, of course, there are many more initiatives that we didn't pick up in this survey, but this was a starting point for us to start investigating what is going on with this condition in Europe. We want to exchange information between our sectors. And today we will try to present you from the ECDC side what we have database on severity of disease. It's our colleague Nick Bundle. And then some researchers from all over Europe will present their research and what they have in their databases on post-COVID condition in children. And the second part of our webinar will be a discussion on what can we do from now on. Are there any possibilities for extended collaboration? We need to understand better the burden of post-COVID condition in children, and this will play a significant role also for the decisions the policymakers are going to make in the near future. Example, for the vaccination of younger children. As I said, we have ESPID members connecting, we have the COVID network members connecting, we have representatives from the National Immunization Advisory Groups, and of course, many colleagues from the ECDC and EMA. And thank you very much for connecting. Just a few housekeeping. Please make sure your video is turned off unless you're speaking, and your microphone is muted unless you're speaking. Please use the chat to post any questions that you want for the speakers, and we will make sure to copy the chat and answer all the questions if we don't have time. Also, please note that the meeting is recorded. And to the speakers, please mention your interest, employer, and project funding at the beginning. We would appreciate that. Thank you. That's from my side. And I will turn off. I don't know if I will stop sharing. And I will see if we can ask Delane again. Can you hear us? Can you please take the floor? Okay. I think Delane unfortunately has some connection problems. When he comes on again, we can ask him to take the floor. Can I please ask our colleague Nick Bundle to take the floor and present? Thank you so much. Nick.
Sure, I'm just going to share my screen.
Thank you. Also, before you start, I need to inform everyone that Nick has to connect to another meeting right after that. If you have any burning questions, please put them in the chat soon. But as I said, we will make sure to answer all your questions if we don't have time. Thank you.
Great, thank you. And apologies, I haven't got my camera on, but that's proving a step too far. So can you see my screen showing the full screen presentation?
Yes, we can.
Great.
Thanks,
Okay.
Nicholas.
So I'm going to talk briefly around some ongoing analysis of surveillance data submitted by EU member states to TESI, focusing on the burden of COVID-19 in children. So this is a pooled analysis using data from 10 countries listed there in the first bullet. And they were chosen on the basis of good sort of external completeness of the number of cases and deaths that they report, but also reasonable completeness of hospitalization status and ICU or respiratory support, which we've kind of lumped together and called severe hospitalization. So there are three outcomes that we're going to look at here, and we've done some selective recoding of unknown outcomes to know. We've divided the data into 4 periods to reflect the period after last summer, so the first wave, where the population of cases was probably very different to what it is more recently due to increased testing. And then also defined at a country level, periods of alpha dominance, alpha delta co-circulation, and then delta dominance, with a median taken for the pooled EU overall. And we've excluded, attempted to exclude incidental hospitalizations by taking out cases whose date of hospitalization occurred before the date of symptom onset. We've removed cases that we can identify as being asymptomatic, so only presenting symptomatic cases, and then censored the most recent 4 weeks of data to remove potential delayed reporting of outcome. And then we focus the analyses on childhood age groups with a main focus on 5 to 11, because that feeds into some other work, another report that we are currently writing at the moment, but also some data presented by single year of age. And so I'm going to go through the 3 points then listed at the bottom of the slide now in terms of the results. So firstly, looking at overall rates of cases and of hospitalizations, and then the distribution of cases and hospitalizations by age. Yes?
Το οποίο
Oh, sorry, someone's talking to me. So these figures are, the y-axis is on a log scale, so do be aware of that. But basically what we can see, the top left here, that case rates increasing in all age groups. The 5 to 11 are highlighted in red, and the 5 to 11 and then the 12 to 17 have basically the highest case rates at the moment. And in line with those increases in case rates, then we see in all age groups subsequent increases in hospitalization rates per 100,000. Now, given that this is a log scale, of course, the absolute values of these rates are much lower. But generally speaking, there is a pretty good age gradient in these hospitalization rates, with the exception of the under ones who are hiding there below, basically almost at the same rate as the 80 plus now. Of course, the older adults are a more vaccinated population than they were sort of in this period where you see much bigger differences. And then at the same time, as a result of the vaccination program, then we see this expected proportional increase in children in terms of their makeup of cases, and also in terms of hospitalizations. Again, this is only reaching 1%, but there has been a steady increase since the rollout of the vaccination program in terms of the proportion of hospitalizations made up by children, although it remains low. So breaking down the top left figure, these case rates just by single year of age now and grouped into these 4 age group bins, you can see what's quite striking here is that basically with every single year of age, so within the bins, then a darker color denotes, one more year of age. Following the same period of the epidemic, then generally case rates are higher with every single year of age increase. I did look at testing data that we have by age to see whether this can account for that. I mean, we don't have it at the same resolution, and it doesn't seem to be as a result of kind of changes in testing or sudden changes in testing that could explain this. So now on to the measures of severe outcome. So we've looked at well, at attack rate, so the risk of having a severe outcome. So the number of cases with the outcome divided by the sum of the cases with the outcome and those cases without the outcome. And then I've looked at the three different outcomes, so hospitalization, severe hospitalization, and death in two different populations. So firstly, amongst the population of all symptomatic cases in these first three panels, and then secondly, amongst a subset of only hospitalized cases. So there it's, you know, amongst hospitalized, those that end up in ICU and those that die. So what's striking here is that, I mean, death is an extremely rare outcome, thankfully. This is in the Delta period, where Delta was most dominant. So really best reflects the situation now and what we can expect to see in the coming months. So mortality remains extremely rare in these. This is single years of age up to 17 years. Obviously, the under ones are a special, and to some extent, you know, the under twos are a special population here in terms of hospitalization and ICU admissions. In the older or the other childhood age groups, there's a slight increasing pattern in risk of hospitalization, but you know, overall this risk is very, very low, and the y-axes are different here to allow the trends to be seen, and you know, we're still talking below 1% and around 0.1% of all cases ending up in ICU. So, but then amongst the hospitalized cases, then a much higher proportion do end up in ICU, and these findings are in line with the published literature. So I looked at this, I'm going to skip over these briefly, but to see whether there was a difference in these trends comparing two periods, so comparing the period of alpha dominance and delta dominance. Obviously, there's been some evidence to suggest that delta is more severe in terms of hospitalizations. I mean, and this is crude, unadjusted analysis. It appears that there may be a signal for the very youngest age groups. The delta period, sorry, I've lost the scale there. Delta period is showing in blue, but really in the other age groups, there's no difference. And this is for hospitalization with nothing really apparent for any of the other outcomes. And then similarly for sex, you know, we know in older age groups than male, amongst adults, male sex is a risk factor, but there's no real sign here for any of these outcomes of that being the case in children. So try to look into the underlying conditions amongst these severe cases, because this is obviously a crucial question when thinking around vaccination policy. So the first thing to note is that in our data set, we have quite a low proportion of cases, unfortunately, with data on underlying conditions. So these are if you look at the total column here, these are the proportions of the cases by age group with any data on underlying conditions available. So a higher proportion of older cases have data, and you know, that decreases there with age. So you know, in our 5 to 11, around under 50% of cases have any information underlying condition. But there seems to be a difference in these childhood age groups in terms of their hospitalization status, whether or not they have this information. So actually, it appears to be underreported amongst hospitalized children compared to unhospitalized children, which is the reverse of what we see in some of the older adult age groups, and probably slightly counterintuitive if you expect better reporting amongst hospitalized cases. So here, this is now focusing on cases that have at least one precondition. So, and then looking at the proportion of those cases with one condition by hospitalization status. And again, looking at different outcomes, hospitalization, severe hospitalization, and then severe amongst the hospitalized cases. So for these first two panels, you can see that having a precondition in this kind of this crude analysis here is relatively more important if you're going to end up in hospital amongst children. There's a bigger difference between the red and the blue bars for any given age group than amongst adults. And I mean, the gap is much more closed here for the severe hospitalization. Put that into a logistic regression model, controlling for country, the time period, sex, with an interaction with between age and this outcome. And you can see that in this fully adjusted model, then what we observed there is also true. So you have greatly elevated odds of hospitalization and of ICU admission, the blue and the green, if you are a case with at least one underlying condition compared to a case of the same age group without an underlying condition. And that holds true for if you're aged between 1 and 17. So what are the preconditions that are affecting these cases? I mean, the first thing to note here is that around between 90 and 70%, depending on the age group, of the cases with data on preconditions actually have no preconditions. So I think we can say from our data, although there's limited completeness from the data that we have, it's not fair to say that it's only children with underlying conditions that are ending up in hospital. That's really not the case. Amongst those that do have information on underlying condition, then these are the most commonly reported. Sorry, they're just abbreviations as they're found in the data set, and they're ordered here according to the total across all these different age groups. And then finally, quite poorly, rushly presented table here, but then we did finally an adjusted analysis for individual underlying conditions which were associated with the outcomes in a univariate analysis using a chi-squared test. Yeah, and then did the same adjusted logistic model to get adjusted odds ratios. This is just for 5 to 11 years of age. So we can see here, if you're 5 to 11 and you have asthma, then you have borderline, well, you have a just about significant 2.5 times increased odds of hospitalization compared to someone who doesn't. What's notable here is that I mean, this is the totals, but we're still talking really very small numbers of people with these underlying conditions, and particularly when we're getting into the severely hospitalized ICU admissions. And I haven't attempted this for death as an outcome because we just don't have the cases to support it. So in summary, severe outcomes do remain extremely rare well, with the exception of the very, very youngest children. Of course, there are issues around the reasons for hospitalization, potential reverse causality. We've done our best to try and strip out incidental hospitalizations, but hospitalization isn't the best measure of severity for children, but it's the one in which we have most cases. And amongst hospitalized cases from the data we have, then yes, having a precondition does increase your risk, but not all children by any stretch who are hospitalized do have an underlying condition. So I'll stop there and thank you for your time.
Thank you, Nick, so much for this presentation. I know how busy the whole surveillance team is. It's extremely interesting, and I see the discussion going on in the chat that it would be interesting to compare with the US COVIDNet and the ESPID network data. But yeah, the data on children is rare, and I think only it looks like ESPID includes children. Okay. Yes. Elizabeth, would you like to just say something about the ESPID data coming out?
Oh, thanks. Yeah, it's not the. I can comment on the ESPID data, but we've got a UK data including all admissions in England in the last year, which was 5,480, which will be published, I think, next week, and just shows very similar findings in terms of comorbidity and very low rates of severe disease. So it's just reassuring that that pattern is reflected in multiple
Yes, thank you. Yeah. And another interesting suggestion that maybe we should benchmark with flu. The problem is, I don't know if we have such detailed pediatric data for flu in our database. Yeah. But yes, maybe.
We have actually done that in the paper that we've prepared. So we've taken the flu admissions of 2018-2019 season and compared them and showed that the comorbidity data is remarkably similar between flu and COVID, which kind of reiterates that message that in young people who have comorbidities, any virus can make you quite unwell.
It would be extremely interesting to read. Thank you. Thank you for letting us know. Okay, so I think we are ready to go on to our second presenter. Can I ask if Delaney is connected? Maybe you would like to say a few words before we have Professor Stevenson.
Hi, I'm not sure. Can you hear me?
Yes, we can hear you. Yeah, you managed to call
Sorry,
in.
I
Yes,
was
thank
having
you.
connection challenges, but I just wanted to sort of introduce this collaboration with ECDC. At the beginning of the pandemic, we worked closely with the ECDC from the ESPID point of view, just to collaborate on important issues for children. And one of the things that did come up was the whole impact of COVID and our lack of knowledge across the different regions in Europe. So this webinar was really as a result of a survey which we issued to ESPID members. And hopefully this will give us more information. But I just wanted to thank ECDC for collaborating with us.
Thank you, Delaney. And can I please remind everyone to mute your microphone or make sure it's muted? Okay. Thank you.
Thanks.
Thank you so much. So, Professor Stevenson?
Yeah, thanks, Tanya. Can you hear me and see me?
We can hear you. Yes, we can see you also. Thank you.
Great. Well, thank you for inviting me to talk about the CLOCK study, which is a national study of non-hospitalized children. So this is not about PIMS and acute or severe disease, which Nick Bundle's been talking about. And it's confined to teenagers, principally for reasons of money. To study the whole of the pediatric population would have cost 3 times as much. And there was a finite amount of money available, about 2 million euros to do this study. It's funded nationally. And if I could have the next slide, please. So I'm presenting on behalf of the CLOCK Consortium, some of whom I'm sure are on this call. Many of them are members of ESPID, and I know Liz Whittaker's there. In the interest of time, I haven't shown everyone's name, but we have collaborators, co-authors from all over England and one from Scotland. So, in keeping with what Nick's just said, since the start of the pandemic, fortunately, death has been a very rare outcome in children. And the majority of children admitted to pediatric intensive care have had a pre-existing health condition. In contrast to that, of course, huge numbers, as Nick showed with his ECDC data, huge numbers of children and young people have been infected with SARS-CoV-2 and fortunately not hospitalized. We collaborate with Public Health England, and they have a record of everybody in England who's ever had a PCR test. They have their name, their postal address, their sex, and their date of birth. And that database shows that between 1st September 2020 and 31st of March 2021, that is that 7-month period, 250,000 young people aged between 11 and 17 had a PCR positive test for SARS-CoV-2, and 1,250,000 people were tested and had a negative test. At the time we applied for the funding to do this on the 8th of December, there were a large number of small studies being published with a very wide range of estimates of the rate of long COVID in young people, anywhere between 1% and 51%. And I can hear some background noise. I think someone's not muted, which is making it difficult to speak over them. if that person could mute, I'd really appreciate it. Thanks. So the methodology is a matched cohort study, which follows a total of 18,000 teenagers, 9,000 who tested positive, and are matched to another 9,000 who tested negative, matched on the only variables we had in the database, which were age, sex, and postcode, or what you might call zip code, geography, which acts as a proxy for ethnicity and deprivation. We made a deliberate decision not to ask, as in other studies, do you have long COVID, because there is no accepted definition of that. Indeed, WHO are currently working on a definition of it, as we are, but at the time of the study, there was no definition. So we just asked young people for the physical and mental health symptoms they were experiencing, and we, in designing our questionnaire, we drew heavily on the ISRAC pediatric questionnaire that had been developed. And we're following these young people over a 2-year period. Could I have the next slide, please? So we also conducted a systematic review, which we last updated in July of this year. And at that point, there were 17 publications globally with more than 10 participants, covering about 15,000 young people under the age of 20. These were all observational studies in design, and in most of them, SARS-CoV-2 infection was confirmed by PCR antibodies, but in some of the studies, particularly the 2 largest ones, it was self-reported. The next slide, please. And what that systematic review is reporting the most common symptoms in young people were the same as in adults, that is fatigue, sleep problems, problems with smell and headaches, smell and taste. I've mentioned the very wide range of estimates of the rate of long COVID in young people who'd been infected. By the time we got funding, so we applied in December, funding was given at the beginning of March, so 3 months had elapsed with peer review and the grant application process. The bigger studies were starting to estimate that the rate of long COVID might be something closer to 2 to 5%, not 51%. The Office of National Statistics for the United Kingdom also published prevalence studies. Now, population prevalence is not the rate of long COVID and people who've been infected. It is the prevalence in the whole population. And they were estimating that in England by June 2021, you can see why we picked to study teenagers, because only 0.16% of children under 11 were reporting long COVID. They asked people to self-report long COVID. Whereas for teenagers, it was 0.51%, and for older teenagers and young adults, it was 1.21%. So the pickup rate's much higher, as with other post-viral conditions like Epstein-Barr virus, like hepatitis. The common experience of pediatrics is that it's older children are more vulnerable to prolonged post-viral syndromes. Next slide, please. So the very simple idea of this study is that we would find at the time of the test many more symptoms in those who tested positive than those who tested negative, but the negative would have some symptoms because in the months of winter months, you would expect a background level of symptoms. We then hypothesized that 3 months later, when we approached these young people, there would still be a small background level of symptoms in the negatives, and there would be a residual core of young people who tested positive with long COVID, and we didn't know what that was. That was the purpose of the study. How much does it decline? And the data I'm reporting here are on almost 7,000 young people who were tested between January 2021 and March 2021. I'm reporting on them rather than the whole 18,000 because they're the only cohort who could describe symptoms at 3 months. Obviously, if you were tested in September 2020, by the time we started our study, you are 6, 9, 12 months post-test, so you can't describe your symptoms 3 months post-test. So this is based on almost 7,000, about 3,500 test positives and 3,500 test negatives. And as we hypothesized, symptoms were much commoner in the test positives than the test negatives. And that's true of 1 symptom, 3 symptoms, or 5 symptoms. Next slide, please. What kind of symptoms did they have about the time of the test? Well, as I've said, about a third of young people were symptomatic. That's in keeping with all other published studies, where probably because of a lower expression of the ACE2 receptor in the nose and lungs, young people can often be asymptomatic but PCR positive. The most common symptoms were headache, tiredness, sore throat, and this loss of smell or taste, reflecting the ACE2 receptor presence in the nose and tongue. And the most common symptoms in those who tested negative were the sort of symptoms you'd expect in a group of teenagers between January and March in the Northern Hemisphere, the symptoms of upper respiratory tract viral infections, sore throat, headache, cough, and fever. Next slide, please. So this is where it becomes confusing. Unfortunately, it didn't work out as simple as we hoped. Our response rate was 13%, which is the same as the Office of National Statistics for randomly approaching people who we have no relationship with. I'm not their doctor. And probably there's a degree of self-selection because 3 months, actually 15 weeks by the time they returned their online questionnaire, 15 weeks post-test, the symptom rate in both groups had gone up. About 2/3 of positives now had symptoms, and about half of negatives had symptoms. Nevertheless, if we compare multiple symptoms, that is 3 symptoms or 5 symptoms, positive people who tested positive, PCR positive 15 weeks previously were twice as likely to have 3+ symptoms and twice as likely to have 5+ symptoms. And I'm sure you as scientists and doctors won't take away, but we have to be very careful with journalists that we are not describing that long COVID happens in 66% of young people who test positive for SARS-CoV-2. Next slide, please. What were the symptoms at 3 months? Well, they were very similar to what's been described in adults, indeed very persisting symptoms of those I described at the time of the test. So tiredness, shortness of breath, headache, persisting loss of smell or taste, and dizziness, which we're increasingly thinking may be due to what we call in English POTS syndrome or postural orthostatic tachycardia, postural hypotension, which is being described in both adults and teenagers in female more than male. Among the test negatives, a lot of overlap, but interestingly, very little with loss of smell or taste, suggesting that test negatives are true negatives and they really didn't have SARS-CoV-2, but they do have a lot of symptoms, and I will try and tease out for you what does this mean in the next slide, I think, or next couple of slides. So what does our data mean? Well, we can do a kind of sensitivity analysis, which is we can assume 2 extreme situations. On the one hand, if our 13% of respondents are representative of the whole population of a quarter of a million young people, teenagers 11 to 17 who tested positive, then about 70,000 would have 3+ physical symptoms 15 weeks later across England, and about 30,000 would have 5+ symptoms. And if we want to decide how many of those are attributable to SARS-CoV-2, then we can subtract from them the number of young people who tested negative who have symptoms. And if we do that, then the attributable number is about 33,000 young people, or 1 in 7, or 14% of the 250,000, have 3+ physical symptoms 15 weeks later. And about 16,500 or 1 in 14 have 5+ physical symptoms attributable to SARS-CoV-2. So over and above being a teenager who's lived through a long pandemic. And those are very similar to the Office of National Statistics estimates of population prevalence based on a completely different methodology, a random sampling of households in England with self-reported long COVID, with parents reporting on behalf of children. Their numbers work out at about 31,000 11 to 17-year-olds. So very similar to the 33,000 if we take our cutoff as 3+ physical symptoms. So that's if the respondents are entirely representative. And the next slide, please. If the respondents are entirely unrepresentative and everybody who didn't bother to involve in the study is perfectly well, then of course the numbers fall considerably. And in that situation, the number attributable to SARS-CoV-2 with 3+ symptoms would be around 4,000 or around 2% of the 250,000 who tested positive. And the number with 5+ physical symptoms is closer to 1%. The latest Office of National Statistics suggests now not showing population prevalence, but now showing rates in PCR positive adults with at least one symptom 3 months later. It's around 5% compared to 3% of PCR test negatives. So again, using a completely different methodology, similar kind of ballpark figures. And the next slide. We also did latent class analysis, which simply shows that there is clustering of symptoms in young people as there is in adults. And those who have a cluster of multiple symptoms are more likely to be female than male. They're likely to be older teenagers than younger teenagers, and they're likely to have poorer baseline physical and mental health pre-morbid, pre-pandemic. Can I go on to, I think, what is my penultimate slide? Next one. So in the systematic review, there were only 3 studies that looked at mental health and gave conflicting evidence, some reporting an increase, some not. And if I could have the next slide, please. I think very reassuringly, in our study of almost 7,000 young people using standardized instruments, which the other studies did not use, there was no difference in the scores on mental health and well-being between test positive and test negatives. And indeed, very little difference in the scores between normal scores pre-pandemic for teenagers in England over the last 10 years. If you ask a different question, you don't ask about young people's own mental health, you ask about, are they worried? Then 4 out of 10 positives or negatives are worried. And maybe that's not surprising. I imagine young people are very worried about relatives, grandparents, exams, school, and society in general, but they don't describe mental health problems. They describe worry about the world in general. And the next slide. So in summary, this is the largest study of children and young people we know of in the world. In fact, in preprint, there's a bigger study from Germany in the last week of 157,000 adults and children. But it is a study of not asking people by approaching them. It's a study looking at computerized medical records. So it's a rather different type of study. This is a study that uses PCR proven status, not self-reported. We didn't ask people to say whether they got long COVID or not because there's no definition. We asked them to tell us what symptoms they had. We had a comparison control group, which is a group of people who've lived through a long COVID. And without that, as in many of the other studies, I think the data would be almost uninterpretable. And it's national rather than single center. And next slide. Thank you. I'm going to, maybe you can stop sharing, Tanya. I think I'm happy to take questions, or you may want to bundle all the questions at the end. I'm happy to fit in with whatever you would like, Tanya.
Thank you very much, Terence. Questions at the I think we'll do questions at the end, I presume. So maybe I can introduce the next speaker for now, and then we can have the discussion later on. So the next speaker, it gives me great pleasure to welcome Danilo Bonsenso from the Department of Women and Child Health in Rome, and he's going to talk about post-COVID-19 condition in children, update from Rome in Italy. Thanks, Danilo.
Hello, everyone. Can you hear me?
We can hear you.
Yes, we can hear you.
Okay, thank you very much for your introduction and invitation. I'm really proud to talk about our experience in Rome in post-COVID condition in children. I really decided to focus more on clinical practice and clinical research, since I knew Stephen Ward was going to present important epidemiological data. I have no conflict of interest to declare, and unfortunately no funds for our study. So this is our disclaimer. And just a few points to better understand our approach. First of all, I fully recognize the role of patients and parents in the recognition and understanding of long COVID up to the former recognition of long COVID by the WHO, and also I recognize some of the advances in basic and clinical research about the pathological events happening post-COVID, mainly adults, including endothelial disease. And as Professor Stefan has already mentioned, current studies are far from being perfect, so we don't know yet how frequently non-COVID is, as we don't even have an agreed definition. But of course, non-COVID has been reported in children almost everywhere in the world. This is at least for my knowledge of current studies. So I will start from some real practice, real routine scenarios. This is just 5 examples of cases I'm seeing in my routine practice of 5 children, adolescents of both sexes having a normal life before COVID. And all of them, of course, had a confirmed SARS-CoV-2 infection, mostly mild or asymptomatic. Only one patient was admitted for moderate pneumonia due to COVID, and I have seen them some 3 to 12 months after their initial diagnosis. They were complaining chest pain, tachycardia, fatigue, difficulty concentration, chest pain, very similar clinical scenarios, and overall they were unable to come back to their daily routine. So first point, although we don't have a definition, the clinical definition we are using in our clinical practice is this one. We are considering non-COVID not any child having any kind of symptom, but a child having a cohort of different symptoms which are having an impact to return to their routine life before their SARS-CoV-2 infection. So at this point, what do we do when we have these patients? And I will show our approach, our case register, and the rationale behind it. So first of all, I'm clear with families. I told them that we don't know yet what to do in these cases, but we recognize the problem. So we try our best to report, recognize, and do research. And this is going to be a journey we do in close collaboration with families and patients themselves. And we
sorry to interrupt, Danilo.
Sorry.
I'm sorry to interrupt. I think people are having difficulty hearing you, so whether you can...
You don't hear me anymore?
Get yourself close to the mic, or... I think there's an echo in the room, so whether or not, if you could use a headset, if you have one, or...
No, because I'm in hospital here. You hear me now?
Oh, okay, don't worry. Carry on. I think people were just having
Daniel, I
difficulty
think you
hearing
actually changed the speakers only. If you check the same settings and a little bit lower.
Yes, I changed some settings, so it's better now, right?
No, it's not. It's still the same. You changed only the speakers on your side. So go back to the audio settings there where you just changed settings. And a little bit below, you can see the microphone. So you go for that, prefer a little bit, a little bit up. 2, 3 steps up. Or that maybe. Let's see if it's better.
It's better now?
Well, I must say
Do you hear me now?
That sounds much better.
Yeah, it's now better. Thank you.
Thanks.
Okay, so I'll start from here, okay?
Yes, fine, Danilo, go on.
Okay,
yes.
so as I said, this is something we are going to do in strong collaboration with the families, although we don't know yet what to do. And we developed our local guidelines, which I try to show you now and also to explain the rationale behind it. So first of all, we start from the ISARIC survey, which has been developed from an international team trying to understand which type of symptoms children are having weeks to months after the acute infection. Although we were using this as a research tool, this is also now used from us as a screening tool to understand which children can develop further clinical assistance. And we usually now wait up to 3 months before doing anything, because from literature and also from WHO definition, but also from our studies, this is a study we have under review, we are seeing that the majority of children are improving within 3 to 6 months, but some of them still have multiple symptoms at 6 months follow-up. So this is the first reason why we wait for the 3 months cutoff before doing something else, unless there are any important symptoms. And then, according to the main cluster of symptoms, we offer a personalized approach. How we decided our personalized approach? This is based on what we know so far about post-COVID condition. We have evidence of autoimmunity triggered by the infection, about viral reservoir, mainly in the gut or particle of viruses, possibility of neuroinflammation during acute or long-term COVID, and also recent evidences of endotheliopathy during long COVID. And last, immunological differences in children with long COVID compared to those that fully recover. So basically, we try to exclude other comorbidities, and we offer an approach very similar to any other child with any of these cluster of symptoms. And we only arrive to the last step with the functional imaging, only to those who still have problems during the other assessments. I'm going to focus a little bit of this cardiopulmonary exercise testing, because it's the test that it really helps us to understand if the fatigue is related with something objective or not. Of course, doing this test requires some months for us. So this also gives time to see if children keep improving or not. And of course, it's challenging doing some of these examinations in the younger children. The cardiopulmonary test allows us to see if there is muscle or cardiac muscle dysfunction, signs of pulmonary vascular disease, or reduced coronary reserve. So back to our 5 patients, those with fatigue and chest pain, we found proof of reduced functional cardiorespiratory capacity and abnormal lung perfusion at the SPECT test. The other 2, case 3 and 4, also have a pathological cardiopulmonary test, and they are doing right these days the third step with the functional imaging. And this child, adolescent with the severe recurrent pain, had proof of pericarditis 3 months after. And this is basically what we are seeing in some of our children with which we found lung perfusion defects. So what we do to these children is the real challenge. Of course, we do not know what to do, and so we offer a personalized approach based on a multidisciplinary approach, and also with active involvement of parents and general practitioners. For example, in children with the abnormal perfusion defects, we eventually decided to start anticoagulation with therapeutic doses for 6 months. The first case stopped right now with improvement in symptoms, and we are now trying to understand how she goes after coming back to routine activity. We have 3 cases in total like this for now. The other, of course, are still under assessment. We are pending the SPECT results to see which kind of treatment enter. And the pericarditis cases are paradoxically easier to understand, since we treat all pericarditis. Of course, we are seeing also other cluster of patients, the arthralgias and muscle pain, or those with chronic abdominal pains, or some with neuropsychiatric conditions. And I think here it's very important to highlight a recent case series from Janama showing the CNS production of anti-SARS-CoV-2 antibiotics. Of course, all this has some limits because this is not a trial, but it is very challenging doing it current state of knowledge, because we don't even have a definition of long COVID, and this is a big issue for having ethics committee approvals. But of course, we are trying to understand what other people and colleagues are doing around the world, and these are our ongoing collaboration. For the ISARIC long COVID pediatric cohort, Louis Siegfried and Daniel Mablit are coordinating these studies, aiming to understand the burden of long COVID, and still Daniel is trying to develop a core outcome set of outcomes for pediatric long COVID. You've heard already about the clock, and then a few words I want to spend about these studies coordinated by the Netherlands, which is trying to understand how we are managing in real life life these long COVID children, because I really think it's important now to shift from surveys to real practice. And so far, 21 hospitals from 17 countries have been involved. Here are the email if you also want to contact us in this important project. So in conclusion, we really have increasing evidence of long COVID in children, including pathological events. We are better understanding that there is a spectrum of manifestations. Of course, it's management and treatment. It's extremely challenging, and we need strong partnerships with patients, parents, and also coordinated international collaborations, and hopefully some funds for real-life studies of pediatric long COVID in children. And last but not least, this is gonna definitely improve also the understanding of all other post-infectious conditions. Thank you very much, and sorry for the microphone problem.
Thank you, Danilo, for that update from Rome. I think the next speaker is Dr. Nicole Tophner from Dresden in Germany, who's going to cover pediatric traces of post-COVID-19 in Germany. Thanks, Nicole, for giving your talk.
Thank you very much for inviting me, dear colleagues. My name is, as you said, Nicole Tophner, and I'm working in the Pediatric Infectious Disease Department of Professor Berner in Dresden. I'm a member of the steering committee of the German Society of Pediatric Infectious Diseases, and I'm partly funded by the German National Pandemic Network, NAPCON. Today, I'd like to talk to you about tracing long COVID. Tanya, I sent you my slides. Could you please open them, or shall I open them? Yes, perfect. Thank you. So today I'd like to talk to you about tracing long COVID in German children. And let us ask first, do we need to trace long COVID in Germany? Or is long COVID all over? It's in the newspapers, in online news, in the discussion about SARS-CoV-2 vaccination on children, safety precautions in schools, and many discussions about the burden of pandemics. On the other hand, I can have a look around, for example, in Dresden in my daily pediatric life. Next slide, please. Where are these patients here? Some would say they sit at home with a chronic fatigue syndrome and do need to be found. Some primary pediatricians would say, I know 2-3 of them, and I care for them when they need me. In the long COVID outpatient department within our Tertiary medical center, some colleagues say there are few who need expert opinions and further diagnostic assessment, but very rarely stationary treatment. This is in line with our ICU colleagues who say we don't have these long COVID patients here. Our biggest problem at the moment, infants and even toddlers with RSV infections, and the ward is full of them. So how common is long COVID? Next slide. If you look at this excellent review, which we have already heard about today, we find the academic data on long COVID are as heterogeneous as in daily life. They vary between the first reports in Italy of 60% and a non-detectable difference of SARS-CoV-2 positive and negative school children, e.g. in this German school study. So I very appreciate our interesting discussion on long COVID today. Next slide. In Germany, we set up an expert group for long COVID together with many colleagues from different cities and universities who take care for long COVID patients or parents who want to have their kids checked for long COVID. And we started to discuss nationwide. It's a very likable and efficient working atmosphere at this roundtable, to which over 10 German pediatric societies of different subspecialties sent their representatives to. We started to work out a definition which we think could be helpful for pediatricians in Germany to decide if a patient. We started to work out a definition which we think could be helpful for pediatricians in Germany to decide if a patient potentially has long COVID and or needs further workup together with pediatric psychologists and psychiatrists. We developed an interdisciplinary recommendation for further diagnostics and potentially symptomatic treatment options to summarize the current state of knowledge and guide medical care if it's needed by our primary pediatricians. And these recommendations are very similar to many aspects which Daniele Bernisteni has presented. Besides, next slide, please. Besides, very early in the pandemic, the German Society for Pediatric Infectious Diseases started this large survey for SARS-CoV-2 infection cases, which became very well accepted for patients with COVID-19 and pediatric inflammatory multisystem syndrome, PIMS. As you can see, next slide, please. Here, for example, with weekly updates of the current situation of hospitalized children and adolescents with COVID-19 in Germany. It's an additional survey with further details on the clinical phenotype and disease course of these children, in addition to the national survey of the Robert Koch Institute in Berlin, which covers the total German population. Here you can see the results of last week. Out of 300 German children hospitals, nearly half included at least one patient in the survey, and in total around 2,000 cases have been registered, which is around 30 to 40% of all children and adolescents of the Robert Koch survey. And 5% out of these children with acute COVID-19 need ICU monitoring or treatment. The PIMS survey was set up in the same way, and it was also very well accepted by many pediatricians in Germany. In contrast to the post-COVID survey, which was also set up in April this year, and until now covers less than 100 cases at all. Which kind of studies will be better trace pediatric long COVID patients in Germany? Besides many very good local and oligocentric studies going on in Germany at this time, I like to mention the next slide, please. The German National Pandemic Cohort Net. This is a governmentally funded nationwide patient platform to recruit patients for different research questions regarding COVID and beyond, with deep clinical phenotyping, biobanking, big data collection, and so on, to assist in elaborated phenotyping of SARS-CoV-2 patients in Germany. In this national pandemic cohort, next slide, please. There's also a large multicentric prospective control matched study. Next slide, you can please click a few times. So there's also a large multicentric prospective control matched study on pediatric long COVID patients ongoing, in which our pediatric infectious disease group and our primary physicians in Dresden are involved as well. As this needs time, and we do need some answers now, next slide, please. We supported our colleagues from the Center of Evidence-Based Healthcare and the group of Professor Schmidt at the Technical University Dresden to analyze German healthcare data on post-COVID. The analysis covers 38 million people, so about half of the German population, including around 12,000 children and adolescents with confirmed SARS-CoV-2 infections. We defined symptom and diagnosis complex from the codes used by the health insurances, and in total aggregated 96 predefined outcome variables. First of all, 3 main groups called physical health, mental health, and an overlap group. And secondary, yes, please, next slide, and secondary organ-specific subgroups, such as cardiac, pulmonary, and e.g. gastrointestinal diagnosis and symptom complexes. Next slide, 2 clicks, please. Yeah, we just included patients with a positive SARS-CoV-2 PCR proof of infections and did a very detailed and intensive control matching, which you can see here. Next slide, please. For all health outcomes combined, incidence rates in the COVID-19 cohort were significantly higher than those in the control cohorts. This in both adults and children and adolescents. Incidence rates of children were consistently lower than in adults. However, they can consistently be detected in 10 diagnosis and symptom complexes of the children. And maybe not surprisingly, this analysis revealed, next slide, please, these, next one. These analyses revealed these top 10 outcomes for post-COVID-19 in German children, which are shown here. Among the specific outcome was the highest incidence rate ratio and an incidence rate of at least 1 per 100 person years in the COVID-19 cohort in children and adolescents were malaise, fatigue and exhaustion.
Where are we?
Cough.
They can't hear me, I can only hear them.
And throat chest pain. In adults, next slide, please.
Just 1 second.
The incidence rates were significantly higher in all 30 diagnosed symptom complexes, comprising top 3 dysgeusia, fever, and dyspnea. Next slide, please. For all outcomes, one is previous, sorry. full results for all domains and diagnosed symptom complexes in children and adolescents, you can see here or look up in our medRxiv preprint. And now the next slide, another very interesting finding was that we did not expect it this way was that the incidence rate ratios were similar for both age groups, which we can subgroup within the existing data set, so 0 to 11 and 12 to 17. We found these similarities both within the main groups, and next slide, and also in the organ-specific subgroups. Certainly, this study has several limitations, as by the nature of health insurance data, you cannot analyze the duration of symptoms because diagnoses are only quarterly recorded. So it can be that the detected symptoms last rather short. And you can also cannot deduct statements on causality, as they only show an association of the present SARS-CoV-2 infection proof and symptoms 2 or 3 quarters later. As the data were retrieved from the first year of pandemic, we don't also know about effects of the Delta variant so far, and we cannot deduct total numbers, so that incidences are still missing. However, we can exclude lockdown effects due to our control matching, and the phenotypes we see were detected far beyond long COVID was a topic in daily news. So all in one, this large matched cohort study based on routine healthcare documentation indicates a substantial new onset post-COVID morbidity in pediatric and adult German population. So for now, I will conclude, next slide, please, that I think long COVID is a topic of high media interest, but the medical and social disease burden of long COVID still needs to be defined, as the incidence rates of long COVID are not yet known and our national and international data are very heterogeneous. And I think we do need to keep this in mind when we are asked by the parents of young children who are afraid of long COVID or like to have vaccination advices. Many thanks for your attention, and I'm happy to take your questions.
Thank you so much, Dr. Tophner. It was very interesting and extremely challenging work to do a network of clinicians and other sectors in Germany, I understand. But excellent work.
Thank you.
I don't see any specific question for you right now. And I would like to remind everyone to please make sure that your microphones are muted. We see some people who are still unmuted, please. And I would like to go forward to introduce our last researcher, but not least. It's Dr. Emmi Sarivikivi. I hope I didn't murder your last name, from Finland, and from the THL, the head pediatric infectious diseases. Thank you so much.
Thank you. Thank you for the presentation. May I ask if you received my slides?
Yes, do you want to share? I can share as well.
Yes, please do, because I'm not so familiar with this WebEx thing. Yeah. So thank you. Yeah. I'm substituting for Dr. Helve, who was supposed to speak here, and I apologize for not being as familiar with these data, but I try to do my best. So first, I have nothing to disclose. Next, please. Next slide, please. So this is just to show you very crude graph on the healthcare system in Finland. So we have a primary, secondary, and tertiary care as most of the countries, of course. And if you go to the next slide, this was to show that the pediatric healthcare system is a bit different. So we the secondary care is very close to the primary care, and the pediatric patients are very easily referred to secondary and tertiary care if they have some symptoms that are not really common. Next, please. So for pediatric symptoms, secondary care catchment overlaps very much with primary care, and it's likely that those children that have chronic symptoms are rapidly referred to secondary care. And this is important important to understand when I'm going to show you the study, the design, and our results. Okay, next please. So we did 2 different approaches to catch pediatric post-COVID or long COVID symptoms. First, Finland is a very small country, and we have very close contacts with our pediatric clinic. So we did simply surveys to those colleagues there to ask them whether they have seen this kind of patients in their hospitals. And then the other approach is to analyze register data. We have we did a few different approaches. We looked at recurrent visits in any healthcare level within 6 months after lab confirmed SARS-CoV-2, and we compared these numbers of visits to RSV and influenza diagnosed children. Then secondly, we looked at ICD-10 codes that could indicate long COVID diagnosis. We'll show you more closely later. And then the third study was to see whether there was increased need of care after the diagnosis as compared to the time period before the diagnosis. And this was also done to COVID positive children and also RSV and influenza positive children. Next, please. So our surveys to tertiary and secondary clinics were simply questions on how many patients they have had in the hospital, and then also if they had seen any children with prolonged symptoms after a COVID infection. And the first survey was done in August this year, and then there were only 4 cases in the whole country that were reported, and then the second survey was actually last week, and now the total number of cases that had been detected in these hospitals was 9. As a background information, I mean the population of children under 16 years, our pediatric specialty is for under 16-year-olds, so it's only 911,000 children, and the number of confirmed cases so far or until the end of October was a bit more than 30,000 in the whole country. So just to give perspective. Next slide, please. And then the registry-based approach of an estimate of burden of disease. So we identified COVID positive pediatric cases from the National Infectious Disease Registry, and we looked at their healthcare contacts, i.e. visits to polyclinic to physician or emergency department, and also treatment periods of ward, irrespective of the reason for visit for the following 6 months after the positive test result. And then a similar collection of data was performed for cases positive for influenza and RS virus from earlier years. And the age was defined by the time of initial test positivity. Next, please. I apologize for the small numbers, but here you can see the first column is age, so it was by the year. Here you can see from 0 to 12, and then the number of positive cases for the different pathogens. The first column is influenza, and then there is coronavirus, and then RSV. And the other numbers are like mean visits per age group during the study period. So and then there is the standard deviation. So you can see that the numbers are very much alike, and there is no clear difference in the different for the different pathogens. Next slide, please. And this is the same for the primary care visits. And here the numbers are again very similar to each other. Next, please. Then the second study was a diagnosis-specific analysis. So we just took all healthcare visits for certain ICD-10 codes that we thought could possibly indicate prolonged COVID symptoms, and here you can see the specific codes that were used, and then the same codes were picked for all visits individually, not like by patients. So we just looked at the specific codes, and the main diagnoses were only used. And next slide, please. And what we then did, we compared like these two age groups. I mean, we were looking at 5 to 11-year-old kids mainly because of the there is a evaluation going on specifically in this age group because of the vaccination. Evaluation whether the vaccination should be implemented in the program. So we looked at these two age groups, 5 to 6-year-olds and 7 to 11-year-olds, and this is for this G93.3 and primary healthcare visits. So this is the total number of visits that were coded in the system, the registry. So quite small numbers, and there was no increase or decrease clearly seen. Next, please. And then the same thing for the secondary and tertiary care visits. And as you can see, there is no clear trend. At least not in 2020 or 2021. Next, please. And then this is for fever for unknown reason, and the numbers are of course a bit larger here, but no clear trend during the past 2 years. And this is for primary healthcare again. Next, please. And the same for secondary and tertiary care. Next. And this is for headache, the same thing, and we can see the next one. And this is for, again, secondary and tertiary care. There might be stomach ache still coming, so you can show the next two slides quite. Yeah, thanks. And then the next, please. So the third thing that was done was that all contacts to secondary and tertiary care 24 weeks before and after the positive test for COVID were searched, and this was kind of a self-controlled approach. So only coronavirus positive children were included, and we used the kind of washout period 2 weeks before and after the date of positive test. Those visits were excluded, and then all children with no contacts to healthcare during the defined period were also excluded from the analysis. Next, please. And this is like the epidemic curve for COVID-19 in Finland in general, but this is just to show the time frame. I mean, because the catchment of infections, because there was this 24-week period before and after that had to be seen. So this is ending in late spring or early summer. So no delta period here. Next, please. And this is secondary and tertiary care visits and hospitalizations 20 weeks before and after the positive test or the washout period by age group and gender. And as you can see, there are again nothing special in either age group or by gender. So quite similar curves here. Next, please. So to summarize, we did not find any registry-based evidence on excess healthcare use after laboratory confirmed COVID in children that under 16, or any excess disease burden with lab confirmed COVID regarding those non-specific ICD codes that were used. And we did not see any constant increase of healthcare service use in the before-after study either. And of course, I mean, this is just a crude analysis, and we know that this does not exclude any rare or sporadic events, but it certainly does not support the idea that prolonged symptoms after COVID infection would be very common in this age group. And the hospital survey data was consistent with these registry-based studies, because the suspected long COVID was really rare. And of course, I mean, we have quite few cases in general, but I think that we know quite well what's going on in the different parts of the country, because Finland is such a small country. I think this was all. Thank you very much.
Thank you so much, and thank you for coming on in the last minute. And it was an extremely interesting presentation, because we know how well your registries work in Finland, and it's really amazing. You don't find anything, basically. But do you think that's because you have low incidence in Finland in general, and especially low in children?
Well, I personally think that we should see something if there was going something on. But of course, I mean, we have been testing very actively, and very many of the children that have been positive have been asymptomatic, and all in all, I mean, I think the number of hospitalized children so far is 120 or something like that. I mean, during the whole pandemic in the entire Finland, and approximately half of them are under 1 year of age. I mean, under 12 months, which is, I mean, that age group is very easily hospitalized, at least here, and I think everywhere else as well. So it's really difficult to say. I think we have experienced very extensive waves in the pandemic, and kids have been infected, but we don't really see very much severe disease, luckily. So I would be happy to hear any or have any comments on this if somebody has. Thanks.
No, it's very interesting. It kind of feeds the discussion that there might be something genetic also playing in, or something else. We need to think of different things. I will ask my co-chair, Delane, to go forward to take care of a few of the questions that we have in the chat.
Thank you, Grista, and I just want to thank Emmy for that sort of perspective from Finland. I think what we tried to do when we chose these speakers, rather than it being a comprehensive look at what's going on in Europe, we were choosing different parts of the region and just getting a snapshot of what's going on, and I think that just represents the difference in different areas, and I think that was really insightful as to the experience in Finland versus Italy versus the UK. So I think those are all very important questions and issues which we can discuss shortly. Just a few questions for some of the speakers. I think for Terence, there was the issue of social deprivation within the clock study and how important you think that is.
Thanks, Delane. Well, it seems to be important in a lot of studies of adults. We used geography or zip code, if you want to call it that, as a proxy for deprivation. So small area postcode. It's not perfect, but we didn't have social class at the time we matched. In it, we have a PhD student just started who's going to approach a smaller sample of these young people, and then we'll be able to ask a lot more about parental occupation, education, social class, income, other deaths in the family, and we'll get much richer data. But we weren't able to for deprivation. So we understand what I mean by postcode or postal address, using that as a proxy for deprivation. Yeah. Okay. Thanks.
Yeah. Thanks, Terence. The other question, I think, which you've answered in the chat already, was regarding those who are where there's no PCR positive test, and do you just want to expand on some of the chat that you've put on?
Yeah. Thanks, Delane. So I think the power of this study, and indeed of the large German study that Nicole Tophner presented, is to have a negative control group. Many of the early studies and single center studies just report test positive. Now, there will be a background of morbidity and symptom level in a group of young teenagers who've lived through a long pandemic. Their schooling's been disrupted, their exams have been disrupted, their relationships with their peers and friends have been disrupted. They've been forced to stay at home with their parents. This isn't normal adolescent behavior. And so you need a group of young people as a negative control group who have never had SARS-CoV-2, but have lived through the pandemic. And unless you have that group to compare to, I think it's really hard to interpret self-reported rates of anything, frankly, I think. So having a match group who we know for sure, and we can follow them longitudinally, if they become SARS-CoV-2 positive after a test, after the index test, we would know and we would exclude them, then I think that is very powerful, having a control group in this kind of study design.
Yeah, I agree, Terence. I mean, a control group is going to be important, but nevertheless challenging to find in the face of a pandemic, I'm sure. Okay, thanks. The other question was for Danilo regarding whether the data you presented was a case series or the national picture. I presume it was more a case series. Is that correct?
Yep, I started from a case series just to try to reflect the rationale and the background of what we are doing in the clinical practice, what type of case collection or interventions what we are trying to do to these children, which fortunately are relatively rare as clinical scenarios, but we are seeing, I confess that these are type of presentations I've never seen before, since I was seeing some messages about the frequency of those conditions. Of course, I just want to clarify, I wanted to show that perspective because in studies, one of those studies, I have also done one of them, when in several studies and surveys, we just collected a number of signs or symptoms which were reported from the parents. This does not mean that having any of those symptoms, this is long COVID. That's why I wanted to try a kind of a translation more on a real life clinical setting, because translating those presentations in a research protocol, it's not very easy. So that's why I try to give a bit different perspective compared to the others.
Yeah, thanks, Danilo. Few comments in the chat. Some of them are sort of relating to the fact that may not be region only, but also bias and methodology. I suppose that's going to be the challenge with analyzing all of the sort of prospective or retrospective data analysis. But a broader question to all the four speakers is how much and how would the recent WHO COVID consensus definition need to be adapted to apply to children? So maybe, I suppose that goes back to methodology and definition of cases. And I'm not sure whether the speakers would like to comment on that.
I'm happy
Please
to
mute everyone.
comment. Delane, I'm happy to say briefly, so we've presented twice to the WHO. They are working on a definition for young people. They're adults. And it's using 100 carers, experts, and young people to come up with a definition, which we will be publishing also. And we want to try and get that aligned with WHO. But yeah, it is tricky, Delane. You're absolutely right. It's tricky to come up with a definition of a condition for which there is no biomarker, no diagnostic test, no pathology. So at the moment, I think it's probably something that will evolve over the next year, I think.
Thanks, Terence. It's a rapidly evolving field and rapidly changing. Any other comments from any of the other speakers?
Yes, I also think it's maybe too early to adopt the definition, because then it also needs to be adopted again when we have even more experiences and it's rapidly evolving. And so maybe, we will learn more about within the next months, and when the first results also of the prospective control match studies will come up.
Okay, thanks. Another question that's been asked is, has anyone been able to look at difference in educational attainment between those with confirmed COVID and a population without? And again, the control population is always going to be challenging to find, but whether anyone's looked at that specifically.
Yeah, personally, we have not done yet this type of study, although this is definitely a very interesting topic. It's difficult to know because we need very large control groups. It's very difficult to organize and needs lots of funds. Although I think it's interesting because we have in those clinical real life settings families, and I also have read on the parents support group of children and families asking for the possibility of hybrid school frequency because there are children that report difficulties in keeping at school at full time as they were doing before, including children that had very high educational standards before COVID-19.
Thanks, Danilo. Any other comments or questions anyone wants to ask before we move on to the sort of final bit of the discussion, which is sort of how we move forwards? Okay, yeah, I don't see any other questions on the chat. So yeah, thanks everyone for your involvement. I mean, this was I'm sorry, I've had connection problems in the beginning and didn't get into the presentation, but this was an initial meeting that we wanted to have, between ESPID and ECDC, just to look at the impact of COVID-19 on children in Europe. And I think, as a society, ESPID felt that there was a need to recognize the significant impact on children. And so this was really a starting point, and our ECD discussions were really quite fruitful and have led to this webinar, which is to try and think about how we move things forward to try and represent children and the impact that COVID-19 has had on them, and how we collaborate across a vast geographic region, just to try and think about how best to adequately support and provide care for these children. So I think this was now an opportunity for us to start sort of thinking about some of these broader issues that we may want to discuss. I'm not sure if sort of from the ECDC point of view, there's any additional sort of comment regarding the way forward.
I would like to thank you, Delane, for being available despite the trouble connecting, and also thank all the speakers also for being so prompt with their time and helping us be on time, actually a little bit ahead. And I would like to introduce my colleague Anastasia Faris, be coordinating a little bit the discussion in the second part of this webinar, and our colleague Marco Cavalleri from EMA, who would start with a short intervention. Anastasia, please. Thank you, everyone.
Thank you, Margarita, and thanks, Delane. I think first we will invite Marco from the European Medicines Agency. He will say a few words about the ongoing discussions now with regard to consideration of vaccination in this population. And of course, we from ECDC as a public health agency are very interested in this, and is one of the major reasons that we wanted to have this discussion here today, is because of consideration around this as a population issue related to young people. Marco, please go ahead.
Thank you, Anastasia. And indeed, I was very interested in the discussion here and the data that all of you brought up. So thanks again to all of you for this. Indeed, the main point, as you know, that we are in the middle of reviewing an application from the Pfizer-BioNTech vaccine Comirnaty for a potential approval in children 5 to 11 years. And as you know, the data that are underpinning this evaluation are based on the prolongation of their large randomized clinical trials also in this age group. And today, in the New England Journal of Medicine, there was the publication of the data with respect to safety and immunogenicity. This study indeed is based on the concept of immunobridging, so demonstrating that the level of immunity, particularly humoral immunity and neutralizing antibodies in this age group, and using a reduced dose, because indeed here the proposal is to use a dose that is 10 microgram compared to the 30 microgram in the adult dose. The immunogenicity indeed would be the same as what's seen in young adults and adolescents with the same vaccine for which ages it is already approved. And of course, with respect to the safety, this study is important and informative, but still is not able to capture adverse event that might occur quite rarely. And clearly one area of our main interest. Please mute yourself. And indeed, one area of our main interest on the safety point of view would be with respect to the incidence of myocarditis and pericarditis, and whether these are occurring as well in young children compared to what we've seen so far in young adults and in adolescents. So beside the assessment of this clinical trial, which might not be overcomplicated, if I can say so. What will be important when we will have to draw the line with respect to potential authorization and defining what is the benefit risk in this population, a very important aspect is indeed the understanding of what is the burden of disease in children 5 to 11 years of age, based on what we see in terms of infection, mild disease, but importantly, severe disease, hospitalization, and long-term sequelae. And this is why we were so interested to understand what is currently known and what is the current evidence, and to what extent the data that are available today could help us and inform us when we have to make this balance of benefits and risk in this population. Not forgetting that in the context of a regulatory decision, we need to look at the benefit risk primarily from the perspective of the individual, so not from a perspective, and therefore the benefit that might come from transmission could be an important aspect that we may take into account, but cannot be the primary measure of the benefits of administering vaccines in this age group. And that's why we were so interested, and we are still interested to understand better what is the incidence of, let's say, PIMS and MIS-C in Europe, as well as we've seen a lot of data from the United States, but much less from Europe, and also other important aspects of the infection with this virus in this age group, taking into account what also colleagues from ECDC have shown around the fact that hospitalization in this age group is not that frequent and actually is the lowest among all the entirety of the pediatric population. But nevertheless, it looks like this happens. And also importantly for our decision-making process, we need also to understand whether indeed only children with risk factors will end up in the hospital, or whether there are children that have no risk factor but still end up with hospitalization and severe COVID or PIMS and MIS-C. And we understand that this is not yet clear-cut, and there is a need of collecting more data. So unfortunately, for the time being, we have to live with what we have. But since decisions, and we are asked, as you know, by the entirety of Europe to as soon as possible, we need to take in advantage of what is available now and to look at the evidence that we have now. So that's why I'm very grateful to all of you and to ECDC to have set up this webinar. And at least this gave us a chance to review a little bit where we stand and what is currently available. And maybe my last comment, that I take note that indeed with respect to post-COVID, post-acute COVID is still very much uncertain to what extent this is happening. And it's very difficult at this stage to have a clear picture around the incidence and to what extent this is part of the burden of disease in children, and how much this should have a clear-cut weight in our definition of the benefits of vaccination. So I think I will stop here, and happy to hear more comments that anybody may have that could help us in our decision-making process. Thank you.
Marco, thanks, Marco, very much. It's really, really important that I think we have this discussion now, and certainly it's not the last word on this burden issue, but you're in the unenviable position of coordinating the decision making before we really have complete data on this, and so that's we'll be interested to hear this in the time ahead. Do any of the ESPID members or others want to make any comments related specifically to the vaccine discussion now, or react to anything that Marco has said? Perhaps any of the panelists or others. It's a bit difficult to see hands, so I would say just unmute or indicate in the chat if you want to make any comments there. We also want to ask Oana Kontu to please mute herself. She seems to be unmuted. Yes, okay. Then in that case, if there are no questions.
I have one.
Please go ahead.
I have risen
Yes.
the hand. So
sorry, I can't see the
this
hands. Go ahead,
decision, it's very important to take much other aspects into considerations. For example, Finland has a general program for flu, UK has, Germany does not have. So if you compare the burdens, and then for Finland comes in the epidemics and leading now to myocarditis. So for Finland, even that they have a flu program, I think the decision is quite clear. Now Germany has to ask the question. I'm German. Germany does not have a flu program in children and never considered one so far. So is a relative risk of 1.5 in the big study for most variables, is that already decision in our data enough? I have fundamental doubts on that. And finally, the study in the children from Pfizer was not powered to detect myocarditis at the same level as the experience so far. So only they can say we do not have more myocarditis than in the 12 to 17 years old, but no more.
Thank you for that comment, Josef. I think, Marco, do you have any response? I know these are.
No, yeah, I think it's a fair comment. Of course, the problem with these pediatric studies is that when you look at rare events such as myocarditis, it's very difficult to capture in the randomized clinical trials pre-approval a good understanding of what is the incidence of an adverse event such as this one. And we have always to rely to larger observational study post-approval because we cannot do otherwise. It would be too complicated and will require trials that would be too large and will delay also potential approval. So this is a bit of a dilemma that we always have and we will always have with respect to this type of rare adverse event. And we cannot find an easy way out. Here, of course, the FDA tried to enlarge a little bit the sample size from 2,000 to 3,000. But in actual fact, when we think about the incidence of myopericarditis, this is not a big difference. And you will not be able really to spot what could be the real incidence here. So that's something that unfortunately we cannot really understand and evaluate with a precise incidence pre-approval.
And of course, the EMA coordinates the pre-approval process, but every country's NITAG makes decisions for the country's implementation. And so those discussions will happen thereafter. And of course, have already started. There is a NITAG are here today, but there's a meeting of the NITAGs on Friday, specifically looking at this topic, where some countries will share the data or the considerations that they have, and so there'll be more to come on that. And if there's interest, we could perhaps have another discussion jointly with ESPID, with the NITAGs in the future when looking maybe at eventual implementation issues around this. We also today have focused on long COVID. We haven't really gotten into the mixed C issue at all. So if there's interest, we could also have a discussion on that. But we felt we needed to focus a bit today so that the meeting wouldn't be too long. There's a lot of interest here. We wanted to spend the last few minutes just asking for your thoughts around collaboration. So you've seen that from the ECDC side, the data that our colleague Nick presented is on the acute sort of severity of COVID associated with infections that are diagnosed, but we don't follow up within European surveillance, or the public health agencies don't have longer term data. This is what you who are working on the clinical sectors have. We've seen really interesting examples of that from the presentations we had today, from registers, from clinical studies, from the clock study. But so far there's not necessarily a European sort of harmonized approach to this. But we heard about some interesting examples. This pediatric long COVID care study, for example. We know that the Orchestra, EU-funded Orchestra project, has a work package that's looking at this a bit. And so we're wondering if there is scope or need for any additional inputs or accelerated sort of work between public health, where we are very interested in the burden at population level in order to understand, this will feed vaccination programs and decisions around those things, but also evaluating programs and prevention and sort of schools programs. And then on the clinical side, you're very interested in the sequela and following up the patients that you see in clinics. We've had very successful examples of collaboration across public health and clinical sectors, for example, in the HIV field, where we've found very fruitful collaboration on HIV continuum of care, for example, where we actually need to work together to measure this very well. So we're curious if there are ideas or appetite for enhanced collaboration between ESPID and ECDC and our network members in the area of long COVID or on the mixed C issue. So yeah, some thoughts on this or examples as to how this could look would be very useful to hear from you about maybe inviting Delane and other ESPID members to speak up.
Thanks, Anastasia. I mean, that that was part of the reason we sort of convened this webinar, and it was like, thinking about how we move forward and continuing the engagement, because I think we feel there's mutual benefit between our two societies, ECDC and ESPID interacting, just looking at the overall impact on children, which I think is really important. And there's so many different things that have been raised at today's webinars that would warrant a whole meeting on their own. So I think this is really important, but this is for me a starting point. Maybe my other ESPID colleagues can intervene if I'm speaking out of turn, but I think this would be a really important opportunity for us to engage with ECDC. I think we have different perspectives. ECDC probably have a lot of the epidemiological data, but I think many of our ESPID members are at the front line of facing the pandemic and the impact that COVID has had on children. And so I think trying to work out a way we can collaborate together and continue collaborating, I think would be really important. And maybe my other colleagues, I know Liz and Terence are on this call, and they may have different views, but I think we should be engaging and continuing this process. I asked my other colleagues from ESPID to give their input as well.
Please just take the floor, Liz or others, if you would like to.
Excellent. I agree. I think it's really crucial that we collaborate. I'm very happy to get involved. There's both the research and the inpatient, or not inpatient, the healthcare seeking group. So there's the clock study, as well as those who are actually coming to healthcare that we're collecting data on, which are quite different cohorts. We are collaborating across that spectrum, because I think we really need to know the full phenotype of these young people, both those who aren't missing and aren't having functional impacts of these, as well as those who are. And so that data is being gathered in the UK, and really think that there is much better to be in numbers. Yeah. Very happy to work with anyone.
Yes, it's the same with me. I would think it's very interesting, especially when we think that maybe the very strong long COVID phenotypes are rare or more rare than we expect them at the moment. And we could then share also biosamples or to work this up, because maybe the very ill people with long COVID are just a few, and there would be international collaborations very helpful for.
Thank you, Nicole. And yeah, it was quite enlightening. The Finnish colleagues had such a different perspective of things as well, and so I think it would be really good to have sort of a good representation from all over Europe. I think that'd be really important. Any other?
Maybe I can add something from my German, and also like from the study I presented, because I think it very well supports the Finnish data, actually, because if you think of the total numbers included in this health insurance data, we deal with like 20 children with long COVID in 12,000 SARS-CoV-2 positive cases. It's just that the incidence rate ratios that you can detect an incidence, so that as the study says, that there is differences and you can see effects of long COVID, but the numbers, the total numbers are very less, and that fits very well with Finnish data.
Yeah, I just to come back in on the UK data, that the number of children experiencing persistent symptoms is very different from the number of children who are unwell and debilitated by persistent symptoms. The number of children across the 15 MDTs in the UK is not huge, considering that 70% of our 12 million young people have had SARS-CoV-2 infection at least once in our setting. Those numbers are low, but they still need input. We still need to understand what's going on, and we still need to understand if vaccination is going to be beneficial or not in that cohort. Those are the questions that really are outstanding. And as we go through vaccinating these age groups, we have to collect that data along the way as well. This isn't going away. We're going to be vaccinating on an annual or semi-annual basis for the rest of these children's lives.
I don't know if any people who represent the NITAGs who are here may want to say anything with regard to the type of data that they would need to make decisions. These discussions are already ongoing in countries, and there's just a few members here, but certainly in a situation like what we heard from the Finnish data, that it's not very compelling maybe to introduce this, particularly beyond the pandemic period. I mean, now in the winter we expect to see a lot of high circulation, but hopefully beyond that we see lower community transmission, and then what is the role of children? And every country will need to make that decision dependently. So it'll be really, really interesting, I think quite tricky discussions ongoing, where we need to pull the best data that we have as it's emerging.
I would have a comment.
Yes, please.
May I again? Sorry.
Yes, of course.
I think it has to be viewed in a much broader perspective. I was running research network in my earlier life. And if you compare to endemic coronaviruses, for the children, when they get a primary infection, it's always pandemic. So coronavirus in children, they make hospitalization when they get a first infection. But it was never a burden of disease, which we considered to get mad about it. And the other observation was that in the endemic coronaviruses, at least in more than 50% of the children, there was the second pathogen. So the attributable risk was tricky. That's not the situation yet with this virus, but it will be. And I think, as I said, what makes this virus so much different, that we now for the children have this different scale, and for flu we never had it. And that is an important question in the whole orchestra within all the airway viruses, to put this, as I said, into perspective. We lose perspective because we all run in, or most run in the same direction.
Thank you, Josef. Indeed, agree. We've had some interesting things pointed out in the chat in terms of different areas on which many of them come from Liz Whitaker that we would need to look at, or could sort of questions, I think, that are pressing. And it seems that there's a large appetite for collaboration. And so we will consider this together with the leadership of ESPID, what this could look like, sort of more concretely, and come back with a proposal. It sounds like there is maybe interest to have future exchanges like this, and that is not very difficult to plan. And so I think that we should signal that that is something that we could do. But then look at more concrete ways of collaboration, whether it be sort of some kind of data pooling study, or looking to collaborate more closely and maybe widen or support some widening of one of the existing projects. So we'll come back on that. I think our time is nearing the end, so I'd like to hand back to Delaine and Agoritza to close the session for us.
Thank you, Anastasia.
Thank you, Anastasia, for that, and thanks for all the input from so many people asking, presenting, and also asking questions. And I think I'll hand over to Agarista, just with regards how we move this forward, because I think our collaboration between ESPID and ECDC is very important, and we should be working with each other in the future, and I would strongly support that. We really need to sort of capture what's going on in children across Europe, so that that's very important for our society to be involved with, and we value our interaction with the ECDC. So Agarista may want to comment.
Yes, I would like to concur and thank you. We are also looking very much, like Anastasia said, to contact the clinicians and get their input. And we will certainly think about doing maybe a second webinar with more research around Europe to get more ideas. But we definitely see a lot of interest, and we will come back with something more concrete for the researchers if they would like to collaborate and everything. And we see that there is active discussion still going in the chat about if and why children should or not be vaccinated, and if we should get all the data together. So that's extremely interesting for us. I would like to thank you all again. We saw many people logging in, and that's really, really nice for this activity. I would like to thank the speakers again, thank Delane and the members of the network, the members of the NITAGs and my colleagues who connected. Thank you very much for attending this webinar and hope to see you again in our next activity. Thank you.
Thank you, everyone.
Thank you for inviting me. Take care.
Thank you,
Bye.
Marco.
Thank you. Bye-bye.
Thank you.
Bye, everyone.
Thank you, Delane.
Bye.
Thank you, Tanya.
Bye, everyone. Delane, would you mind staying on?
Thanks, bye-bye.
Disconnect.